And Dale, do you want to share the pack on the screen?
Certainly will. Okay, can you see the pack now, William?
Yes, I can. Yeah.
Great. Just so people know, I can't see anything else with hands and bits. So, oh, hold on, it's not moving on. Let me just go back to presentation and put it in a different format so I can share. Okay, try and make that bigger. And we'll move to the next slide. So just the usual housekeeping for the meeting. Sorry, my IT skills aren't as good as Lisa's. But please do use the chat function to tell us your name and the organisation that you're representing, so everyone on the call knows who's who and can chat. When you want to say something, please do raise your hand, and hopefully you've got the icons displayed there that you can use to help put your hand up. When you're not talking, if you could please put yourself on mute, and so we don't have other background noise going on while people are speaking, please. That would be really helpful. Okay, so for the agenda today.
Lyndall, it's Ruth.
Yeah.
Do you want me to just mention, if you put your cursor over the grey horizontal line and pull down, you'll be able to see full screen. There you go. Pull it down.
There we go.
Ruth, you're a legend. Thank you.
I'm going to be quiet, I promise.
Thank you. I was wondering how to get rid of that. That's a great IT tip. Thank you. Okay, so William, do you want to do the apologies for us, please?
Yes. The first apology I want to flag up is from Lisa. Unfortunately, she's had a bereavement, but so isn't able to join us. So thanks very much to Helen Mitchell for stepping in at the last minute. So Helen's going to be taking some minutes for us, and hopefully keeping us in line sort of IT-wise if we stray off. And then we have other apologies from Ian Bullock, Ray Danzik, Jill Moforth, Steve Bond, Sarah Lineage, Helen Smith, and Sherry Jones. And Janet Backhouse will be joining us after 1:30. Okay, let's move on then to the minutes and the action log.
Do you want me to bring those up, William?
Please, yes. Let's deal with the minutes first.
Okay. Okay, so hopefully you've got the minutes displayed on your screen now.
I mean, these have been previously circulated, so I just want to check that there isn't anything that people want to raise that we're not going to be dealing with in the meeting. No? Okay, can we confirm their accuracy then for those of us who were at the meeting?
I confirm they were.
Yeah, I'll take silence as assent. Okay, and then if we look at the action log, okay, you'll see the green ones are still in progress. Most have been completed. If you can just scroll down, you can see that there's a significant number completed. In Lisa's absence, I won't go into the update any in progress ones. Hopefully we can follow through afterwards on that. Okay.
She's put notes on the spreadsheet with those. That's great.
Okay. Right, to get back to the agenda then, the main pack.
Yes.
Okay. Okay, so if we move on to the okay, so next slide. This is just a very brief report about the last executive meeting. You can see from the slide what the key things that the meeting focused on. So next slide, please. You should all be familiar with these priorities, but I just wanted to, I thought it was appropriate to remind ourselves of what they were in the context of looking at, well, what did we learn? Next slide, please. Here's a list of the lessons learned which were highlighted at the meeting. I'm not going to go into any of them in detail unless people have particular concerns. I suppose the only one I want to just comment on is the final one. It's clear that there is a recognition of the value of co-production, but clearly we need to be able to see that working in practice as we go forward. But there's a clear recognition of its importance. Next slide, please. So, performance summary. What can I say in summary about that? That we need to recognise the effect of COVID, therefore its impact on waiting times. And concerns were raised about the level of non-compliance across the Alliance. So, and these were reported. Move on as follows. Next slide, please. Again, I don't think any of those are unexpected in the context of where we've been in recent times with the pandemic. Next slide, please. This was a particular issue which I raised, which was supported by a number of other people, and agreed by the executive, that there was a problem with kind of not reporting in time, and clearly that can have a significant effect on a number of things that are going on, particularly pilots. And I've highlighted the faster diagnostic framework. So I think there is an issue about recognising that there can be some IT problems in terms of different systems not talking to each other, but nevertheless I think there needs to be a recognition and an acknowledgement that trusts need to be doing better in terms of trying to meet the required timescales, because otherwise that can have a significant knock-on effect. Okay, next slide, please. Yes, I did briefly highlight on the introductory slide that this was a key thing on the agenda, but we're very good to have Ruth being able to join us, so she's going to address that now. So Ruth, over to you.
Brilliant, thanks William, and afternoon everyone. Fantastic to see so many of our partners on the meeting today. And very pleased to be able to kind of share a little bit more details around the priorities for the coming year, really, and hopefully they build on the kind of the plan on the page that we ran in the 21-22 year. There's a lot of consistent themes, which tells you that we were not entirely able to achieve all that we wanted through that year of COVID, but there's certainly some additional focus that I'll run through with you now. But just to say, having William present at the executive board has been really fantastic, and I know it was only your third meeting, William, but it was terrific to really have your voice lend itself to the importance around data. I think you've got a bit more focus on this later in the agenda, but yeah. It is a real challenge. Some of you may have read BBC today, and there's a further report that's been published that talks about some of the challenges of working in the NHS, and it actually likened the NHS trying to run itself like a blockbuster video store in the age of Netflix, which I thought was that was Sajid Javid. So it's difficult to hear that, but I would say that there are elements that are very accurate in that, and so we really need to keep focusing on how we can improve that data in the way that it comes in. So having you there at the board, William, and lending your voice to that and the importance of that has been very helpful. I'm very happy to take questions as we go. I might just get Linda on the next slide to really blow it up a bit because the font is very small, but I'll also leave the link in the chat so that people can go and look at the plan and the page in their own time. But do ask any questions as we go as well. And we'd love your feedback on any of this, and certainly hope that we can co-produce and co-deliver as we go through the year with yourselves as a really important part now of the TVCA governance structure. So I'll just lead us in to say that what you'll be aware that the cancer agenda is really big. We as an alliance, work with well over 1,000 different stakeholders if you look at all of our different networks that we reach out into, and if we don't try, it can feel like there's too much to try and describe what the focus is. So we try and distill it down into what are our absolute key priorities. So this isn't exhaustive, but hopefully is something that's a bit more digestible for colleagues. So our three priorities for this year are the first one is, and has been, a priority for since the kind of development of alliances, is around how can we improve early diagnosis of cancer. But what's become very clear and even more clear through COVID is there is potential that we are widening the inequality of access. And we do know that there are areas where people do not come forward as early or have to visit on several occasions before they are then able to access the system. So we are having a really significant focus on how can we keep pushing the early diagnosis agenda, but with improving access to some of the inequalities data now. We really want to do some of that targeted intervention. I'm not going to steal anyone's thunder because I see Salman and Abby are on the agenda as well, and they'll talk more about the Cancer Allies programme, which is a really fundamental part of that. But when I come on to plan on the page, I'll pull out a few things that are really targeting that ED agenda, early diagnosis agenda. Apologies, and pull me up if I use lots of acronyms as well, please. The second key priority is something that links back to the performance that William mentioned, which is not where it needs to be, and also the patient experience very much in terms of how can we ensure that anyone who's referred onto a pathway really receives what we've described there, faster diagnosis, and then it's not just about diagnosis but timely initiation of treatment. So there is a very significant focus in our plan around not just rolling out what are called best practice time pathways, which others will come and talk more about. It's not just about rolling them out, it's about ensuring that they are then adhered to. And the hardest thing is the timing. We all know what steps should be in place on these pathways from an optimal standpoint. And I think that when we've mapped these pathways across the Alliance, the right steps are in place, they're just taking too long to be really basic about it. So we are going to work with trusts, and we have a significant amount of funding that we're directing towards this to say, how can we really look into these pathways? This is where the data comes in that William talked about. We need to understand what are the time markers for all the elements within the pathway. And if we can get access to that, what we think of is quite granular level detail, we can then really start to see, well, where are the patterns emerging where one part of the pathway may be functioning quite well, but there's a real bottleneck either in access to a specific test or access to the reporting that follows it, or it may just be access to the next clinic appointment or the MDT meeting. And if we can see that data, that's how we will be able to, I think, then target investment to where it's really required most. And within that, we should therefore be able to really improve overall what we call this operational performance. So those published monthly targets that we often hear about in the news. So by doing that, though, what is absolutely clear is that we will improve the experience for everyone. Through this forum, but through many other forums, we understand, the impact that having to wait, and also maybe not quite knowing what's happening in your pathway, the impact that has on patients. and family members. And so if this is not purely something that will make things faster, Victoria, who's on the call and leads this for us, you know, there is a very significant aspect here of this programme, which is we want to improve the experience of patients. We want to ensure that they're empowered to understand where they're at their pathway, and they have good access to understanding what will happen as they travel through that pathway. So that's our second key priority. The third priority is something that has, as I say, this is where I think we're developing and growing in terms of what's required. So we've been running, you know, the personalised care programme for a number of years around ensuring that there's where possible, patients are encouraged to enter supported self-management pathway, and where we ensure there's better access to treatment summaries and health and wellbeing events and material. But we also, whilst we continue to extend that out to more and more cancer pathways, there's a bigger focus within the plan this year around really trying to understand where have we got variation in the types of treatment that are offered. And this will focus on a few key tumour sites, starting with lung, but it will extend out to other areas. And this is very much where the rapidly developing genomics agenda will come in, with access to things like Lynch testing and what have you. So there is a significant programme of work, and I think there's recognition that a huge amount of funding has been directed towards that early, either improving early diagnosis or improving the faster diagnosis, but there's recognition that we really need to ensure that we're providing consistent optimal treatment for all patients. And again, where we can learn from where there is best practice, how can we then ensure that's kind of spread more broadly? And that's very much the Alliance role in doing that. The really important thing, though, is that none of those three priorities will be delivered effectively if we don't have what we've called key enablers, right? So these are the things that overlay across these priorities. And as an Alliance over the last couple of years, I think we've worked incredibly hard to really ensure that these are on a firmer footing, shall we say, and more permanency around how the Alliance operates. We have, and I'm not sure if Victoria's come before to demonstrate the dashboard or if you're going to see some of that today, but whilst we don't have all the data that we need, we have developed a significantly improved access to kind of what we call unvalidated, so it's live data, that more or less live, so that we can actually see what's really happening at that moment in time, rather than waiting for things to be published that are often a month or more out of date. So we've got good progress in data intelligence, but we need to do more. And within that, one of the things I mentioned right at the top is how can we work with the inequalities data, which is now coming through on a more formal and useful way to really support, as I say, the health inequalities agenda as well. So that will be a perennial and very central focus for us this year. Then we move on, importantly, to our patient and public engagement as an enabler. And I think when I think back 2 years ago, I think, or a little bit more now, at the way in which we were trying to encourage working with patients and those who have been, you know, involved from a family perspective with patients who, or family members who have gone through a cancer pathway. We obviously had some foundations there, but what we really wanted to do was actually make sure that we were, wherever possible, really trying to drive, you know, that patient involvement and the co-production where possible, and support our priority. I think we've lost the presentation. Sorry, Lyndall. Thank you. And I think we've come really far, but you can put in the chat if you'd like to challenge or ask me any questions about that. We haven't got it right, but I think through this forum, you know, it's wonderful, as I say, to see so many people here. We've got the very definite feed now into the executive board with William. We've had really terrific patient engagement in the rapid diagnostic programme, as well as the personalised care. And not to forget, at every tumour site level, we've really tried to ensure that there is active patient participation at those meetings. I think we're going to continue to develop that, Lyndall, is that fair to say? And you guys are all here to help us shape how we do this, but hopefully what is in place now has real permanency and will help ensure that we really are, as I say, wherever whichever work stream we're looking at, that we've definitely got active patient involvement. And it's really important that we extend, I'll come to you in just a second, Alan, extend out far more broadly to our other networks that work very closely with patients and those who are really trying to support from. I noticed we've got a number of Health Watch colleagues who've come on. And we really want to do more of that, and I know that that's developing as we go. I'm very sorry that Lisa isn't here today to kind of hear some of this, but I think some of the ways that Lisa has extended out to our wider networks has been fabulous, and so really, really good to see so many of you here today. Before I move on, Alice, did you want to come in?
Hi. I'm Alice Clifton. I'm from Health Watch West Berkshire and Buckingham. I just wanted to find out is the fact that, you know, when you say you do it, you know, how do you disseminate that apart from this group to the public? Because, you know, that's very important, because one of the things that we find is how much we put it out there, the public don't seem to get the message.
Yeah.
And, you know, and we need to be better at it. There's got to be something we need to do.
No, that's Alice. So let me, I think Kath, sorry. Shall I hear some, Lyndall, you okay if we take just others, and then perhaps because I think this is exactly where we need to focus the development aspect. But yeah, Kath next.
Yep, go ahead, Kath.
Yeah, thank you. So sorry, I didn't put who I was. So I'm a carer of somebody who's had lymphoma and chair of patient group and part of the Oxford Blood Group. So yeah, so my thinking is that the early diagnosis side of it, it's just what the lady from Health Watch said. It's trying to get the message to the right people. I know that obviously you'll go through the GP practices and they'll see for the early diagnosis bit, and they'll obviously be looking for perhaps different things. But the Prostate Cancer UK people have done an amazing job, and I don't know whether it's because they've got the football people involved with their campaign, but I would say that that's had a really good impact, and so maybe we can learn some lessons from the prostate cancer progress, perhaps. That was just a comment I want to make. Thank you.
Thanks,
Kath. Rob, do you want to come in? Go ahead, Rob. You're on mute, Rob.
Sorry, can you hear?
I can hear you now. Go ahead.
Sorry about that. Yes, I'm the new boy here, but I do have the privilege of managing the Macmillan project within RBH Hospital, and I also run a support group. I was very, very interested in hearing the report about early diagnosis of cancer, which actually is a real hot potato for me. I mean, I think that is so incredibly important. I also noted, so I'm supportive of that. I also noted the comment that somebody just said, excuse me, forgetting, but someone said that I'm not sure the public are aware of all this, and I entirely agree with that. But you know, one other question, which I had from 2 or 3 of my support group members, is a lot of this starts at GP level. And there is there is clearly problems with some GP surgeries, and indeed my own one. You've got to be pretty rough to get in there for a start, to be able to get some service. And a number of mine, and I live in an area where there are many elderly people, and they're all saying what a concern that is, and they don't feel welcome. And I just wonder, for all the good you're doing, and you certainly are, I just wonder if these GP surgeries are really, I mean, they are the front door to this, so they're so important.
Thanks, Rob. Ruth, do you want to come back on number of points there?
Yeah, happy to. Thanks, William. So back to the first comment, although they are all on a theme, really, aren't they? Which is the public. Okay, so I think that if I could be completely transparent, I think we do a very good very good job of educating our wider healthcare system about early diagnosis, and we communicate very well as a healthcare system. What we don't do so well is how we do reach into the public and how we make it meaningful, and remembering that not one message won't resonate with everyone. So, and this is the inequalities bit, which is, I think we're also, when we do try and reach out to the public, we are doing it on quite a kind of well-educated healthcare population. And what we need to realise is that not everyone feels that well empowered about their own health. And so we really do need to look at how do we reach into areas where people don't feel empowered to come forward or don't know how best to come forward. And I think that's one thing. And I'm so aware of time, William. And so
Okay.
Can I just say, can you, for everyone, perhaps when Abby talks about the Cancer Allies, that's where we need your help. How can we do more of that around, you know, kind of locally targeted awareness messaging, etc. So that's one thing. The ongoing, or the access to GPs, I think is again incredibly challenged. I think it would be remiss of me to say anything else. We work very closely with our GP primary care forum, and I think it has been a very, very challenging time to try and maintain what we've been used to, at least even pre-pandemic, with the numbers coming forward. I think that we continue to work with our GPs on a really, really regular basis to ensure wherever possible, now correct me, I'm not quite sure who said this, that when you do go, you don't have to really force the description of what's happening, and that there's an open door and easy way for you to then be referred in. There are certain programs that I'm going to come and talk about on the plan on the page that should improve access, and one of those is fit testing, which is not mask fit testing, but is a poo test for the lower for colorectal cancer, and that has become evident that it's really very, very good in kind of picking up or ruling out cancer. So we want to ensure that that sort of thing is maximised. So we can't solve as an alliance some of the workforce challenge, but we can ensure that the pathways are most effective, and I think that's how I see us targeting that. But I think overall, from my perspective, I think the thing that really does need to develop is what we started out with, which is how do we enable the public to hear the messaging more clearly, and with that, how can we drive up things like screening uptake? And I think that that's the role that we need to play, and that's where anyone on this call who would help us and support how we do that, I think that is the critical, the really burning platform that we need to focus on this year.
Okay, thanks. Do you want to the next slide?
Yeah. Thanks, that'd be great. Right, so this is just impossible to read. So Lyndall, I don't know if you can go down and just press on the plus as much as you can, and I will just pull out some of the kind of key highlights myself as well. So I won't talk about things I've already mentioned. So another key development that we will be rolling out this year is something called the Targeted Lung Health Check programme. So this is to enable those who are at higher risk of lung cancer due to smoking history, etc., gaining access to an initial lung assessment, and where there are clear indicators, access to a low dose CT scan. And this is part of a nationally rolled out programme. We're now into kind of phase 3, and there are plans that this will essentially become a further screening programme in years to come. We have one site, which is at the Great Western Hospital. They are literally about to get going in July, but we'll be extending to a second site over this coming year. And what we're looking to actually operate is a mobile CT scanning pilot that would move between areas of, as we say, high deprivation. We would love some involvement in that programme. It's a really, really high profile programme for the National Cancer Programme. And so I'm sure that's something that we'll bring back to this meeting in due course. But that's a very significant thing that we'll be rolling out. I'm going to leave the Cancer Allies, as I said, and I did mention the rollout of fit testing already, but that is an absolute priority for us. Then if I'm, go on, am I over time?
No, no,
Am
no,
I-
fine. No, carry on.
Okay. The second priority, as I say, really focuses around the faster diagnosis elements, and that really is about getting the right data to drive improvements on those pathways. But it would also be remiss to not mention there is a very significant programme of teledermatology, which is to ensure that high quality images are used to accompany dermatology referrals. And we are part of a national kind of programme there in terms of rolling that technology out. And again, ensuring that those images form part of those referral pathways in. And that's something that we'll work on through the year. Training is already underway with GPs, and we've run one of the courses already. The next one is tomorrow. But again, something that we really hope will ensure and improve that quality of referral. And then I'm going to come on lastly to, as I say, the treatment variation and personalised care. And really, as I say, this is about continuing the programme of personalised care that's already running, but extending beyond breast, colorectal, prostate, including gynecology cancers on the PS personalised stratified follow-up pathway, and really continuing the quality of life mapping exercise. And I think I saw there's some stuff coming up on that, so I won't go into that anymore. Than I have done already. And as I say, that the big development really is transitioning into looking at how we can reduce treatment variation starting on the lung pathway. I'll pop the link in once I stop talking, just so people can gain access to you. Just click the button, it's on our website. But William, hope I haven't overrun too much.
No, not at all. Not at all. I think it's important that people understand what you've been saying. Anyone got any sort of quick final points, questions or points to make? Yes, Peter, go ahead.
Yes. Thank you. Peter Glass, Reading Prostate Cancer Support Group. We have very good support from a dedicated clinical nurse specialist, and we will shortly be going out into Reading Town Centre. A much smaller Reading support group is the Bladder Cancer Support Group, and I have been asked to go out and support them. Easier for me because it's nearer where I live. But I think I'll particularly say is, there's been too much. These support groups have been left, sort out your funding however you can, and good luck to you. But I really would suggest that some professional involvement, and and I'm certainly hoping we're going to be talking later about the partnership between CNSs and patients. Thank you.
Okay, thanks, Peter. Ruth, you want to make any comment on that?
No, I won't. I think it will agree. Things need to be kind of funded and ensured that there is a way of taking the work forward. And I think that as an alliance, we are ensuring that where we are I guess responsible for developing these groups, that we can ensure those forums exist. And so for the wider groups out there, if there's anything that would support from an alliance perspective in us attending meetings, then please do come back to us.
Okay, thanks a lot, Ruth.
Thank you. Thanks all.
Okay, let's move on then to the next item agenda. Abby, I think you're going to lead us into this.
Thanks, William. I believe Salman is on the call, and he will be doing the honors.
Okay.
Thank you, Abby. Hi, everyone. Just want to check. Can you hear me? Okay.
Yep, and it.
Yeah. Thank you. So I'm Salman. I'm a GP, and I'm the clinical lead for the Cancer Allies program. So thank you, firstly, for inviting us to talk about it. I'll just go straight into it. So basically what we're going to do is to talk about the program that we've got running, and hopefully then also invite you to take part in it as well. So could we just zoom out on the slide? Sorry, because I've got the heading on there. Thank you. So essentially, the program is something that we have been effective as an NHS working on throughout the COVID pandemic, and in some cases prior to that as well, which is to recognise that communities, however you choose to define them, have been coming together for many years and organising themselves in ways that are most effective and most influential around the people that take part in them. And during the COVID vaccination work in particular, we saw huge amounts of success when we had genuine co-production, not tokenistic, genuine co-production with communities, and helping them to understand what the unmet need was and how we can help them access the vaccination service. So we've seen lots of success in that program, utilizing that model, and certainly other places have been using a similar model prior to the pandemic, many years with great success. But it's certainly something that as a system we've become much more aware of as being an acceptable methodology to getting better outcomes in communities. So what we've been doing in the Cancer Allies program is trying to do the same thing, which is go out into the communities across our patch and effectively ask them to sign onto this piece of work where they become cancer allies. And what we're looking to do, as Ruth mentioned, is to address the inequalities in cancer. At the moment, we're focusing on the early sign of the early part of the cancer journey, which is around screening, signs and symptoms. And we're currently working, the majority of work that we're currently doing is with cultural and ethnic groups and also with faith minority groups as well. But we're very much aware that this is something that applies to all health inclusion groups, and we're doing more work, particularly with learning disability groups, which we'll come on to at the end. And what we're looking to do is establish a rolling programme. And if you go to the next slide, please. And this program is essentially understanding that one size doesn't fit all, and it's coming and it's what communities are telling us what they need and what resources that we can give, what positive actions that we can put in place to help people raise signs and awareness around signs and symptoms of cancer. And providing reassurance, providing people with the assertiveness that they sometimes need to be able to navigate the symptoms, to navigate the system. And what might be a helpful way to explain it is if I just talk through some of the case studies. If you could go to the next slide, please. And this is generally what we're talking about, the methodology. It's about co-production. We also are using the data as well to help us understand where we're going. So we are looking to see where there is a shortfall. So, for example, in prostate cancer and lung cancer, there has been a shortfall. So that is something that we are going to communities where we feel that that would be a good place to go. But we're also recognizing that we have to work with communities as well. So just to give an example, one of the areas that we have worked with in High Wycombe, there was a very sad case of a young lady who died of ovarian cancer in that community. And as you know, unfortunately, there aren't any screening programs for ovarian cancer, but the community wanted to talk about ovarian cancer. And so they organized an ovarian cancer event prior to us formally working with them, but we were part of those early discussions. And that led us to then talking about, well, what about some of these other cancers, such as prostate cancer and lung cancer, where we know the data is also showing a shortfall. And then we were able to come into those communities and talk about lung and prostate cancer as well. So we're effectively trying to use communities in a way that works for them and works in the practice that they have. So hopefully you can see that this is a genuine principle co-production. We are looking at the data in there, and we are also using communities intelligence for that as well. Next slide, please. So we started back in February last year with multiple stakeholders taking part, giving us a bit more understanding as to what we need to do, and we followed it up with another meeting in March in 2021. And some of those challenges that you see on the slide there around language and literacy, around awareness of services and accessibility will not come as a surprise to any of you, but it just further reinforced the need for something like this. Next slide, please. And again, these outputs around the message is perhaps sometimes not as important as the messenger. Certainly many communities where there is an issue of mistrust in the system because of chronic underfunding and under-resourcing and disparities that they've experienced mean that they actually don't trust what comes out from their GP surgery or that comes out from conventional NHS messages. They're far more likely to trust their community leader or another service user who has been through it and is a local influencer, or their faith leader, for example. And particularly around faith-based communities, we've seen huge progress and huge results actually from working with faith communities, particularly those that intersect with ethnic minority communities as well, to again provide that local, influential, contextualized positive health promotion messaging. again, some of the other findings that we come out around translation. So often when the system thinks about reaching out to minority groups, particularly those who don't speak English as a first language, the first response is usually to translate something into that language. But the feedback that we get is that is not always helpful, especially when you haven't got a messenger who's able to contextualize that information as well. Next slide, please. So here's just an example of some of the organizations that we worked with, which will hopefully help you to hang your hat on the principle of what we're trying to do, but also in terms of the ask for us, for yourselves as a community here. So Nisha is here from Rushmore Healthy Living, and I think Abby, we're going to ask her to speak later on, so we can save that one for later. But Sapa Care in Bucks is an organisation which worked with a group of mainly Pakistanis community members in Aylesbury. We did a talk there. The Nigerian community in Oxfordshire, that was actually something that Abby managed to arrange. And Abby is part of the Nigerian community herself. She lives in Oxfordshire, and she actually reached out to her community there saying, listen, would you be interested in something like this? And they were really, really, really grateful for someone to proactively reach out to them from within their community and link them into the work that we're doing. And that was a really, really wonderful event around prostate cancer. And they're really interested now to do some more work with us because they see that validation of their community and the way their community is organising themselves. And they really have some great ideas as to what more we can do. The Karima Foundation in High Wycombe is another fantastic community group that are doing lots of work around different cancers and different areas of health as well, and mental health and weight management. And again, we've gone in there and worked with them around how we can help shape some of their programs around the data that we have in aligning that a bit better so that we're not working in silos. The Wokingham Health Inequalities Action Group, we've got some local GPs in the area there who are part of local ethnic minority communities and also part of local communities as well. They've been incredibly keen and active in going out there and talking to them. We've got the Nepalese Association of Wiltshire. They've got a group of senior citizens. We've been talking to them as well. The WISE Wycombe Islamic Centre is a faith group in High Wycombe, and they've got a particularly niche North African population there that we've been reaching out to. And the Habib Centre in Swindon is another Pakistani group based in Swindon who are also looking to talk to us around some work that we're doing around lung cancer, and particularly around the low-dose CT targeted screening as well. So that hopefully gives you a flavour of the type of work that we have done and are planning to do, and hopefully with your support we will increase the number of and types of events that we do. So that's a menu, if you like, of what we can do, and we're very open to adding more items to that. So if you do know groups that you're involved with personally, or you know other people who are part of them, then please do put us in touch with them, because we are looking to broaden the group and to work with other inclusion groups that I mentioned. We are looking to align this with the national strategy, which is the Core 20+5 strategy. It is very much in alignment with that. We have funded local initiatives as well. So we have funded Swindon CCG to do some work around developing this programme, and one of the primary care networks in High Wycombe to also align themselves with the work that we're doing. I mentioned that we're currently focusing on the screening and the early detection side of things, because that's where we have the easiest hook, as it were, and the lowest lying fruit. But the intention is to expand it across the into all of the Alliance programme work eventually, but currently sort of focusing on this part here. And as we've mentioned, focusing on ethnicity, age and deprivation. Next slide, please. I mentioned the targeted health check with the Habib Centre, so that is something that is going to be coming online soon. So again, a very exciting piece of work, proactively working with communities who are very keen to take part in this conversation and can identify patients for us in a slightly different way from than we perhaps are used to improve the access to that. This one here is just about personalised care, so we're very much aligning it to the mandate objectives that we've set out in the Alliance to make sure that we have more underrepresented groups taking part in our activities. On this next slide here is a graph of the quality of life survey for the Thames Valley region. It's a bit difficult to see, so I have to pinch in to have a look, but what it shows is that across different ethnic groups, the response rates are lower for those people who are in a non-white group. And that just gives you an appreciation of, you know, these groups are their engagement with the system is different. It's a bit more complex to get into these groups, and therefore that's why we need a program like this, for us to understand the needs of these communities a bit better, to help us understand what exactly is it that drives their behaviours, and what can we do to help improve their access to healthcare. I believe that's the last slide. If we check what the next one is, please. Yeah, so I'll just hand over to Nisha. Nisha's from Rushmore Healthy Living, and she can give us an overview of the work that they've been doing, which is very much in alignment with the Cancer Allies work.
Hello, good afternoon, everybody. Thank you, Salman. Thanks for giving this opportunity to share my project experience with you all. My name is Nisha Tiwari Sharma. I'm the project lead for Macmillan Cancer Education Project in Berkshire, which is funded by Berkshire Clinical Commissioning Group and being run by Rushmore Healthy Living. And we have the partnership with Macmillan, Royal Berkshire Hospital, and CCG and RHL. So it was obviously being funded by Macmillan before, but now it's being funded by the Berkshire because of different regions. What was the objective for this project? And it was the main objective was to support in addressing and improving health inequalities in accessing cancer services among different seldom heard groups, including BAME, for example, different African Asian communities and Polish communities. So my role was like to link with the both communities and service providers, and also the health professionals, so that could link them together and fill the gap between the service providers and service users, where service providers are seeking to improve the health service delivery to the patient, or like service users or carers or general public. So whether it is the patient or like or general public and general communities. So it was very important to work with the community. I would focus only with the how the project works with the community. It was one of the main activities to achieve the goal of this project as well. So this project was there since 2017, now extended up to 2023. So it's a series of extension there because of its importance felt by the different service providers as well as the community. So it was very important to work with the community, meaning like the community volunteers, because of their same languages. Like everybody, we now recognize that how important it is to have the same culture, same tradition, same language, who spoke this kind of their same languages. They could make the conducive environment for the people who need the services and to get the support and seek the support through them. We needed the volunteers to become the cancer champions so that they could provide their support to the community when they need it, and they could, they could signpost them to raise the cancer awareness, general sign and symptoms, to link the community with the service providers, provide relevant information through the different channels on time, and also identifying the barriers from the different communities that prevents them for the early diagnosis, prevention, and also for the treatment. So we needed to support to increase the uptake of cancer screening activity as well. For example, bowel, breast, cervical, which we already know. So how we did it? So it was very important to identify the cancer volunteers first in the community and to recruit them, to get their interest, to recruit them, to build the trust between the project and the communities. So we did it through the different event activities and individually group networking. We used all the means like for the communications that was provided, that was available to us, depending on somebody wanted to talk in the talk individually, or like over the phone only, or like they wanted to be linked with the net, events or activities. So we try to use all the means. And once we got the interest of the community volunteers, we provided training through the Macmillan. So they got all the trainings. Now we have the 25, very dedicated cancer champions, dedicated volunteers providing the services to the communities. They are from the diverse communities. We have the Polish champion, we have Pakistani cancer champion from the Muslim communities, we have from the African Asian communities, Nepalese, Zambian, Sudanese, so different communities, and we are trying to develop that number more. We are still working on that one. So what they do now, like apart from the other activities, say they work with the patient, they support their services to the patient, and they support their services to the community and general public as well. So they provide the information about where to get the local support. They help to set up the cancer information to get the cancer information locally, and where to get the cancer services around their areas when they need. And they talk to people group, help them understand what is cancer and how it is treated, what are the cancer signs and symptoms, when to go and see the GPs. They raise the awareness, they provide the importance of screening program, information on importance of screening program, and support patient and family and carers in different ways. For example, just now, it's happening now, the police cancer champions are providing the two cancer patients, they're providing the emotional support at the moment. So what we have achieved at the moment, like we have cancer champions, they are working on their own from the different communities for their communities. And we have also formed like the cancer support group of the same cancer champions, Reading Cancer Champion Support Group, that provides the forum for them to meet, to share and to learn from each other, and also to link with the other service providers. So we do meet in every quarterly, and then before pandemic it was bi-monthly, but like we are also hit by the pandemic. And we have so far maybe more than 4,000 people have been benefited from the different cancer awareness sessions in the different areas, different communities, and different event. So we have achieved there are more demands of like a cancer awareness session from the community and from the groups, and more volunteers have been empowered, and that there are more volunteers also willing to join this group, and we are working on that one. And so our working area has also been extended as if we compare to the previous 2017 and 18. Now it has been extended to Baksar West. Previously it was only in the South Reading area. So we have shared our learning experience to the different other parts beyond the target area, other parts of the country as well, like in the Kent, Rossmore area, Swindon, Aylesbury, Oxfordshire, and also have provided our learning experience to the different service providers who wanted to, do the similar kind of things in their area as well. So yeah, and I'm very happy that we have also supported to develop the cancer resources in different languages with this help from the cancer champions in the different languages during the COVID time, and other informations like the prostate information, lung cancer information, and different screening of information as well. So I think I will stop here. So pandemic definitely we have been hit by the pandemic, and then there were a lot of challenges as well. So I'll be happy if there are any questions. I'll be happy to respond on that one. Thank you.
Thanks, Nisha. Do anyone have any sort of brief questions, either for Nisha or Salman? No. Okay. Well, thank you very much for that very useful presentation. Sorry, Kath, you've put a quick hand up. Kath, come in, please. Yeah.
Sorry. Yeah, no, it's quite interesting to hear how you got on with going through the community, because it's something that I've actually suggested we have in our GP practice, a cancer champion, linked to the PCN, and it's sort of fallen on deaf ears. So I'm just wondering, the progress that you've made has obviously been to go to the people in the community rather than the community coming to you, if you see what I mean. So how did you, when you first initiated that, how did you broach it with the various community groups? What did you do or say to them to start that ball rolling? Because it's quite interesting, because it doesn't happen overnight. I'm just intrigued as to how you started it off.
Okay, thanks, Kath. Nisha, do you want to come back on that briefly?
Yeah, I was, thank you. And it is very important. I mean, like, at least you raised this one, and because there were a lot of challenges in the beginning, because we started from the scratch, and I had the, like, a lot of experience of how the service providers, like the GPs, we had a lot of interaction with the GPs as well, presented in the GPs, how we work, kind of things, and then the community. So the trust building was one of the main learning from us, because you needed to be, for me, I mean, you needed to be very transparent at what you were going to do, how you are going to do, why you need it, because the cancer itself is very sensitive topics, and then you cannot just raise that issues with the communities unless and until they are really ready to listen to you. So, so that was the very challenging thing. So we tried our best, like, to build our trust, like, okay, this project is for you. And then the services that we provide is for you, and then even this project is not there, you'll have the link with the service providers. You can get their services whenever you need, if you know these kind of things. So if you have somebody to work within your community, it would be very, very comfortable for you, like, to break the barriers, to talk, and then to start that conversations about the cancer. So
okay, thanks, Nisha.
Yeah.
Salman, any final points you want to make?
No, just agree with that. It is very resource intensive, and you're not going to find every conversation yields a result. So certainly our experience has been, for the good few months, a lot of conversations that didn't necessarily end up going nowhere, but it's an investment that we haven't yielded the results of just yet. And the trouble is that when you're so time poor, as we all are, it's difficult to find the time for that investment, and we're very fortunate that the Alliance has recognised this and has given us time to actually do that, and the space to do that as well. So I think that's the first thing, and I just echo what Nisha said about we need to recognise the assets that we have within this group. So it's not just whether you're from an ethnic minority or not. We know that, completely different example, we know that loneliness kills, for example. If you know someone who is lonely in your street, on your neighbour, you can be someone that isn't a champion in that cause. You don't have to have that formal title. So I think just letting go of some of letting go of some of that, I think, is part of it as well, and just not having people feel like they have to have this formal title to be engaged with the system. Everyone has an ability to be an ambassador, a champion for whatever health cause. And as it comes to cancer, if you're interested about cancer, come to us. We will work with you as you are. You don't have to fit into our little puzzle, because often that is some of the challenge that people have. And traditionally, I think the reason we're in this rut, as it were, with inequalities is because it just hasn't worked so far, despite everything. So we just do need to be a bit more creative. But it all goes back to the time that people have to do it.
Okay, thanks a lot, Salman. I know, Rob, you want to come in, but I do want to move on. We need to catch up with the rest of the agenda. So thanks again, everyone, for their contributions. So agenda item 5, the data dashboard. Victoria, you're going to take us through this?
Hi, thanks, William. Afternoon all. I just put my camera on quickly just to say hi. I'm Victoria Sangra. I'm Head of Service Improvement here at the Alliance. I kind of look after the overall kind of data analytics, and also kind of lead on the fast diagnosis programme. So I'm going to do a live demo of the dashboard. I will take questions at the end, but I'm going to switch my camera back off just because of bandwidth. So just bear with me while I share my screen. Right, can you all see my screen? Can you see my dashboard?
Yes.
Okay,
We
so
can.
this is the Cancer Alliance, what we term or we call the data hub. Just a bit of background about this. So this data hub, it holds all the information from the 5 trusts across that kind of feed in across the Thames Valley, and those trusts are obviously Oxford, RBH, Buckinghamshire, Great Western, and Milton Keynes. So all of those hospital trusts have patients that flow through our patch. It holds both validated, which is so the validated data is data that's in the public domain, that has been formally and publicly published, and unvalidated data is data that is not yet in the public domain, and it's just working its way through to the monthly submissions. So from a cancer reporting perspective, the overall kind of metrics or oversight of how cancer is performing is reported on a kind of 6 to kind of 7 week cycle, depending on what that month looks like. So this afternoon, I'm going to focus mainly on the validated, which is the published data, and just give you an overview of what the most recent month looked like. So we're in June at the moment. We do have April's data coming out next week, Thursday, but today I'll focus on March, and then I can give a bit of a backward look in terms of how we've been tracking. I think William had already kind of alluded to at the top of the meeting in terms of what we presented to the board, and I think as I go into it, it's fair to say it's been quite a challenging 12 months, honestly, impacted significantly by COVID. So I'll just wait for this to load. There we go. So what we have here on this page, as you can see, so it's the kind of overall cancer performance, and it's the month of March 2022. So what we saw within March, so this top row here is in relation to the overall Cancer Alliance position, and what that is made up of. It's an aggregation of these 5 trusts, which I'll go through. So in terms of the 2-week wait standards, that's the standard where patients who are referred in from a GP need to be seen within 14 days. For March, the Alliance reported a position of 84.7. The compliance, or the standard that expected standard of achievement, is at 93%, so as you can see below the standard. And there was varying compliances across the trust. So as you can see, Bucks, Great Western, and RBH, just shy of that 93%. Great Western in the 90s, with both Oxford significantly challenged, and I can come onto that a bit more, and Great Western sitting at 88%. In terms of the 28-day, so the acronym is called FDS, and that stands for Faster Diagnosis Standard. This is a new standard that came into formal reporting in October 2021, and this is the first time that in terms of reporting, we look at patients who also don't have cancer. So this standard represents the ability for patients who are referred in being able to have their diagnostics and have an outcome of whether they do or don't have cancer by day 28. The current standard is set at 75%. So as you can see, as an alliance, we were just short of that at 74.3%. And again, non-compliance seen at BHT and Milton Keynes, but compliant positions at Great Western, Oxford and RBH. So moving on, 31-day standards. So we have the first and sub. The first relates to patients who have a decision to treat and need to be treated within 31 days of that decision to treat. So they've had their diagnostics, patients aware that they've got cancer and now need their treatment. So the standard for this is 96%. And as you can see, it's been very challenged across the patch with non-compliant positions at alliance level, but also on trust level. And then subsequent treatment standard relates to patients who have had an initial treatment but required further treatment, and again non-compliant position against the so this is actually aggregated, this subsequent treatment is aggregated as an overall position, but I'll go into it on the other page when I go into historic overview, because it is broken down into subspecialties in terms of types of treatment. And then the 62-day position is patients, so this is where they have been treated The standard for this is 85%, and this is where patients who are referred in via their GP should be seen, diagnosed and treated within 62 days of them being referred into secondary care. And as you can see, again, very challenged position.
There's no data visible.
Can you not see my screen?
I can see the first page. I don't know how other people are, just the over categories. It's not moved from that for me. I don't know how it is for others.
So can you see the petrol gauges, as I call them?
No.
No, can everyone else see them or no?
Problem.
Yeah,
Oh,
I can see them,
I can see them.
Victoria. Yeah.
I can now.
Okay,
It's
perfect.
appeared.
Okay, perfect.
Thank you.
No, it's okay, no worries. So as you can see, against that 85% standard, most trusts sitting, so we had 3 trusts sitting within that 60% category, 1 within 70%, and then Great Western just above 81% there. So that's the overall performance. And then this element here is just around the activity. So these are the actual numbers of patients that travelled through those pathways. From a 2-week wait perspective, what we could see was that, so give me 1 second, if I hover over this. So in March, there was 9,579 patients seen within that 2-week wait standard, and that's across, and then it's broken down at trust level. The other thing that we can see, so if I hover, you can see the rolling trend of the last 4 months for each trust in terms of the number of 2-week wait patients that they're seeing. Likewise with the 31 days, this just these figures here provide confirmation of the total numbers of patients treated and each trust on that 31-day pathway. And again, if I hover over, there is the trend line of what that looks like. So these numbers here relate to the March figure because that's what we're looking at. And again, this activity here relates to the 62-day treatment. So for prime example, in March, there were 640 patients that were treated across all of the 5 trusts, and then obviously it breaks it down at trust level. What we also have the ability to do, so we are just working, so one of the things to kind of highlight is that we are continuously developing the data hub. So again, Ruth had alluded to it, that we plan to be able to track those best practice time pathways, and that's something that William really supported in kind of advocating at the last board in terms of ensuring that we get that data. But what we can do here for the larger tumour sites, I'll just show an example. We're able to drill down into those tumour sites. So I can give you an overview of, for instance, the breast pathway. So this data that we're looking at now, and as you can see, it starts to paint a different picture as you go through to the different tumour sites. So if we look at breast pathway, what we could see is that from a 2-week wait perspective, but Great Western and RBH were able to see them, to see that standard. They met the standard of seeing at least 93% of patients who travelled through their pathway within 14 days. And then we've got 2 trusts who was just, so Milton Keynes at 92.5% and Oxford, who were significantly challenged. They only saw 9.2% of the 502 referrals that were referred into the trust within 14 days. What was good is that all of the trusts, if you look at the 28-day FDS standard, so as an alliance, 91.3% of patients, so that's a total of 93% of the 1.9, so 1,943 patients that came in. They were seen with, well, they had an outcome in terms of whether they had cancer or not. So we kind of met that, and we saw Milton Keynes meeting that 31-day, and actually 2 trusts were able to ensure that they treated the majority of their patients within that 62-day pathway. The other one that's also quite interesting to look at is lower GI. If I just flip to lower GI. And what you can see, this is a tumour site that is and continues to be quite significantly challenged, and it's one of our key focus tumour sites for the fast diagnosis programme. So again, only 1 trust hitting that 2-week wait standard, with challenges across the other trust. Again, only 1 trust hitting the FDS standard. and pretty challenged in terms of compliance against the number of patients. So in 4 of the trusts, less than 50% of the patients seen or treated were treated within 62 days. I think the thing to add, so if we look at, for instance, Bucks, there was 40% of those patients, but the total number of patients that were treated was 5 for March, so 40% of that 5, so probably so only 2 patients probably, or 1.5, depending if there was a shared treatment, they were treated on time. And then you can see the different numbers here. I'll just quickly flip to a historic view, and we can kind of just look at how we're tracking. So I'm just going to move this back to the overall alliance position. So what we can see, as I kind of alluded to, it has been because of COVID. So down here provides an overview of, so we can go back as far as when the pandemic started, and what we can see. So with the exception of May 2020, and that's probably because it was in lockdown, so it was you know, a small cohort of patients that were coming in to be seen on the 2-week wait pathway. We have seen we have been recording non-compliant positions for close to 2 years now. So this is something that we need to really work on and really drive improvement on, alongside supporting the achievement of the 28-day standard. But so if I move to the 28-day standard and just look at what that has looked like, that does tell another picture. So although that 14-day hasn't been achieved, what we can see is that we have been consistently compliant, with the exception of 3-4 months in total where we haven't met that 75% standard in terms of being able to inform a patient of whether they do or don't have cancer. And I guess from an alliance perspective, and I think from a national perspective, this is something that's really key now, because what we want to be able to take away some of that anxiety where patients are just kind of waiting, you know, they don't know what's going on, their pathways are being elongated. But what also the drive for this is to then support patients who do have cancer being able to be expedited and then start to improve that 62-day position, which again has been significantly challenged. So non-compliant within the last 2 years at all. And the highest that we've been against the 85% standard would have been in December 2020, where it was at 81.6%. So that's the closest we've been. And as you can see, since kind of if we look since a year ago today, we have just been on a downward trend, and that is as a result of COVID and just the impact that it's had on pathways. So that's kind of an overview of the dashboard. Like I said, there are key elements that we're progressing. We hope to be able to transpose the overall best practice time pathways and be able to really track them to understand where the challenges and nuances are. Not that we don't understand them as an alliance. So in addition to this, how we use this data is we have a bi-weekly meeting with trusts where we ask them to kind of present an overview of what their current unvalidated data is and talk through what their current challenges and mitigations are. We also undertake monthly reviews of the patients that sit in what we call in the backlogs. These are patients that are on the patient tracking lists that are sitting above 62 days, and we really want to understand what's happening there. And then we also ask the trust to provide oversight of how they're managing their harm reviews in terms of patients who've been waiting in excess of 62 days. So
okay,
that's the overview.
That's you know, there's a lot of detail behind that presentation. Can I just clarify that this information is available on the Alliance website for people to?
So this is what I'm going to do, William, is I will Lyndall's been in touch, so I will put some slides together in relation to the published data, and we'll then put that into the pack. Okay,
that's great. Thank you very much. Okay, does anyone have any quick questions for Victoria? No? Well, thank you very much, Victoria. There's an awful lot of work behind that, and I think certainly what you finished off with in terms of the non-compliance is clearly worrying, and it's, you know, it's one of the points I flagged up at the beginning of the meeting in terms of looking at end of year performance And clearly there needs to be an awful lot of work to improve that. So thank you very much again. Okay. Let's move on then to item 6, psychology.
William, Kath had a question there. If you don't
sorry,
mind.
Kath, I missed you. Sorry, Kath, go ahead.
Yeah, my question was, it's great seeing all the data, and yes, there is a lot, but for me, it would be much better if we could see it in terms of numbers of people that have been affected. I know you can drill it down, but it would be great to see those figures. So say, take for breast cancer, how many didn't hit that mark in each trust? We're sort of doing it reverse way around. We're saying what we didn't hit with percentage wise.
So yeah, that can be moved into patient in terms of kind of numbers. So numerical, we've got the ability to move it from kind of percentage to numerical. So happy to put a version of the numerical figures into the pack as well.
Okay.
Yeah, that would be great. That would be great. Thank you.
Thanks, Victoria. Okay, thanks again, everyone. Okay, let's move on to item 6, the psychology on Susan.
Hi there. Thank you. Thanks for giving me the space to talk about the mapping project. So I'll just quickly share my slides with you. Oh goodness.
Susan, can you see my slides on the screen?
Yeah.
Hold on. Have you put it up?
Yeah.
Yes, it's showing.
Hopefully,
yes,
you can see my slides. Yeah.
I don't know why it's not.
Are you not
see tell me when to move on, and I'll move them along for you. Okay, you just talk to them, Susan.
Okay.
Thank you.
Sorry about that. Yeah, no, I just want to thank you for this, for being able to talk about the mapping project. Just a brief background. I'm a doctor of psychiatry. I've got an interest in looking at health service quality and looking at sustainable health. So I was appointed by TVCA and funding is being provided by Macmillan. So I'm working with a consultant psychiatrist called Dr. Luke Solomons. So a mapping project is basically, it's almost looking, it's similar to looking a survey, looking at a snapshot of the service provision. So we're looking at psychological care support in the oncology services. And sorry, are the slides still visible to everyone?
Yeah.
Okay, so so it's looking at a snapshot of psychological care support services. So could you go on to the next slide, please, Linda? So the reason that we recognise that there is a huge proportion of emotional distress and underlying mental health issues in patients with cancer, and previous studies have shown that at least a third of patients are not picked up and not receiving treatment. So on to the next slide, please. So we often—
Susan, I think you've taken control. What I can see on the first slide.
Okay, can you move on to the third slide?
You've taken control of the screen, so do you want me to take control back?
Sorry, can you let me just remove this then, because I can't seem to see.
I'm showing the slides now. Can you see them as you talk to them or not?
Now. Yeah, I can see it now.
Okay.
So the third, so we talk about cancer survivorship, but we're less likely to talk about quality of life and how emotional distress is important to be identified early. But fortunately, there's now tools that can be used, such as the holistic needs assessment, and there's a lot of evidence behind this. So I'm sure most of you would have heard of this. So according to current guidelines, this is being done usually at the point of entry for the patient, and ideally before discharge as well. So it's just very important that the emotional distress is identified early, as this has a huge impact on the prognosis of the patient's journey. And ideally, they will be signposted appropriately after the emotional distress has been identified. So on to the next slide, please, Linda. So it was important for us to include patient partnership groups within this mapping project. As we approach integrated care systems towards July, we can see the importance of increasing the role of patients and healthcare providers who would become more and that things should become more responsive to the patient's needs and preferences, and in order to deliver better healthcare. So there are various ways in which the patient can participate in healthcare. On to the next slide, please, Linda. So there are 6 main domains for the healthcare providers need to consider when looking at quality of services, specifically looking at the effectiveness, the efficiency, the accessibility, the acceptability, equity, and safety for patients. So on to the next slide, Linda. So out of those 6, the 3 that stand out, the deficiency in equity, deficiency in accessibility, and deficiency in acceptability, it's important for us to really engage with patient partnership groups, because those are factors that that they can really influence. So on to the next slide. So this is just a slide to highlight what equity is. I'm sure some of you might have seen this slide, but for those who haven't, the left side shows 3 people of varying disadvantage, and it's quite clear that they're all being propped up, given the same level of support with the boxes, but the more disadvantaged person on the right is clearly not benefiting from the provisions, or in this scenario, they're not able to see the game that's being played. So there isn't really much gain in this scenario, but the reason why equity is more important is that those who are less advantaged are being propped up higher. They're given the same benefits as others who have more advantages, and that's why it's more important to focus on equitable services. So on to the next slide, please, Linda. So as far as accessibility is concerned, we have to be inclusive as a service. So we have to give importance. We have to look at the background of patients and understand their circumstances. So depending on, as this picture highlights, some patients may not be able to read or write English. Some may not have access to computers. The patients might have various disabilities that impair them, but it's important for us to be accessible and be inclusive as a provider, so that we're taking into account all of these things. So on to the next slide, please, Linda. So we hope to be acceptable to patient partnerships groups. It's not just about what's acceptable to us, but what's acceptable to the service providers. On to the next slide, please, Lyndall. So it's important to keep a narrative open with the people who've had lived-in experience of cancer. This is not just a current narrative, it's really an ongoing narrative, so that we have to keep the dialogue open. So on to the next slide, please, Linda. So in the future, it's really trying to understand how we can make psychological care support more more acceptable, accessible, and more equitable. On to the next slide, please. So how we can do things better to increase the quality of the services. So this requires a process. So if we start at the bottom left, where we're looking at an analysis, where we're involving all stakeholders, not just in secondary care, but in primary care. We're involving patient partnership groups and community engagement as much as possible. We're conducting a situational analysis. We're looking at specifically now what the provisions are. We're looking at what the goals are going to be in the future and how we're going to address these goals. So our strategy will be looking at choosing interventions that would focus on quality, and this leads on to implementation and continuing to monitor progress. On to the next slide, please, Lyndall. So how we can do things better. It's important that we focus on how we can engage with patient partnership groups. The aim is to, I know in the past focus groups might have been conducted, but we will have to consider how, moving forward, how we will further engage with patient groups. So this would be inclusive of diverse communities as well. So part of the mapping project will be to formulate questions for focus groups. And so this will probably occur between the months of July to August. So it was just to understand everyone's points of view and whether there are any questions about this.
Okay, thanks, Susan. Does anyone have any questions or points they want to make? Yes, Pete, go ahead, come in. You're on mute, Pete.
Yeah, there we go. Can you hear me okay?
Yeah.
I think this is, I'm fascinated by what I've just heard, because I think this is probably one of the most important areas for head and neck cancer patients after treatment. The psychological problems that head and neck cancer patients are enormous. And I was wondering if Susan could be in touch with me. I'd like to discuss this more with you, because the patients that we see at our meetings, the psychological problems are enormous, absolutely enormous.
Okay.
Yes, definitely.
Okay, thanks, Susan. Thanks, Pete.
Yeah, I think we've discussed this at previous meetings about when the holistic needs is done and when it's right for the person. Because although you have static times to do it, sometimes that's not the right time for that person. And I just wonder whether, I think you said an initial diagnosis before.
Yes, at the moment, that's what's happening in the majority of places. It's when they're initially diagnosed and towards discharge as well. But it's an ongoing process. I think that more people need to be trained. This is a tool that needs training, and so that it will be identified at any stage. There are other tools that are being used as well in Oxford, but so that it's more regular.
Because I think the thing is it's fine doing it at discharge, but quite often the kick in with the psyche is after you've left the hospital, and so that's why I was asking that question. Is there a a support that will happen beyond that, because I think there probably should be, and also how you engage with the different groups of people.
That's
You know, I'm not just talking male and female, but you know, and etc. But it's important that some people will open up, some people will say, and perhaps go to Maggie's and talk to somebody in Maggie's because they've had a cancer diagnosis. But some people will not accept that diagnosis of cancer for a long, long time. So I think it's an open-ended piece, and I don't think it should have a deadline of time on it. Anyway,
That's really,
thank you.
Thanks, Kath.
One good thing about the mapping project is there'll be a steering group. A steering group has been formed consisting of psychologists and lead cancer nurses, and as well as TVCA GPs, so that there'll be a continued dialogue with the patient partnership groups, because like you say, it's you know, it's something that has to be revisited, but you know, as far as once they're discharged, I know the GPs are conducting the cancer care reviews to so I don't know, at this stage we're still looking at what's being done, and hopefully we'll, you know, see what areas of further need there are. From you shrugged when I said cancer.
Yeah, sorry, I shook my head because I don't. In our experience, that hasn't happened. The cancer review through the GP hasn't happened and doesn't happen. And you know, I know the situation with GPs, and it's just one other task they have to do, which is why I was asking: is it possible that something can be done later? I know you've got, you know, you're going from primary to from primary to secondary care, and secondary care back to primary care. But I think there needs to be a better interface there. That people drop through the cracks. So I don't know how that could be done, but yeah, thank you.
Because it varies very differently on each trust site. Sorry to interrupt.
No, Lindale, you want to come in?
I'll briefly comment on that, Kath. There is some work that's being done looking at some nurses now going out into primary care and working with GPs to actually do the cancer care reviews and support people with that sort of living well and beyond and the stratified follow-up. So there's more to come on that, and I think that's a recognised area that needs to have bolstered support there. But my question actually was, Susan, are you coming to the group to actually ask for them to participate in your focus groups and questionnaires, and are you going to share it out that they can share with their support groups, and perhaps Health Watch, who's on the call, might be able to share it out as well, so you can have a good number of people attending your focus groups and answering the questionnaire?
Definitely, it would definitely be beneficial for me to have members of this group as well. What the hope is to form focus groups, especially with more minority underserved communities. So any advice or that I can get from this patient partnership group as to how best do it would be invaluable, or any suggestions really.
Thanks. How can people get in touch with you then?
I will take your email. Thank you.
Okay.
Perhaps, Susan, would you put your email in the chat?
Yeah.
And then that way people can email you to say that they're interested. Okay. And I think I can see one of the Health Watch team have put their email in there for you as well.
Thank you. Thanks very much for that. I will definitely share my email right now.
Okay. Thanks, Susan. Right then, item 7 in Lisa's.
William, I've had my hand up for some time.
Oh, sorry, it hasn't appeared.
Is it not?
No, it's not showing. Sorry, go ahead quickly, please.
I'll make a quick comment, really, because taking into account all that's just been said, I think one of the most underused assets we all have is support groups. I really do. We have a support group. It's dwindling in numbers, by the way, because there is not enough communication, and so many members of our support group are older people who do not do Zoom, cannot communicate with us. We've lost half the membership now, almost, and it's steadily going south. So I think they're a most underused group, and I see really no way they get seriously enough recognised, other than by, I will give great credit to Macmillan who do so, but they are really your support group, your obvious communication group, all of them. Lastly, there's another group of people we've not really mentioned in all this, and this is the older people who are not IT literate. I would think half of our members would not do Zoom because they just cannot cope with computers. I don't know what the answer to this is, but it is a serious problem, and we're missing a lot by not engaging with them somehow. We have reinvented our monthly or bi-monthly meetings, and people looked down their nose at me and said, "Is it really time to meet?" Well, it was, and they all turned up. Which is,
I think that ties very much into the equity point that Susan was making, and it's certainly something that we all recognise, and particularly the issue about people having the skills or not having the skills in terms of being able to deal with Zoom or being comfortable. So I mean, there's a whole bunch of issues there which I think we need to come back to and kind of deal with in more detail. So thanks for raising them. Okay, so I think we need to move on then. So item 7, in Lisa's absence, Victoria's going to give us a quick rundown on the survey. Victoria, are you there?
It's actually me, William
sorry.
Lindell.
Sorry, Lindell.
I'm going to cover this for Lisa. So just to say that the National Cancer Patient Experience Survey, it was something that sort of started many years ago and is done on an annual basis. And it came through the various national cancer strategies that we've seen throughout the years. And it's sort of reconfirmed in the most recent NHS long-term plan that they very much want to co-design and make sure that we have patient voice and feedback on services. There is a specific group that oversees the National Cancer Patient Experience Survey, and that advisory group has representation from patients, clinicians, charities, and patient experience leads across the country. So with the survey, how it's done is that normally October, early November, they go out to each of the trusts. There's a sort of data collection that needs to happen, cleansing of the data that needs to occur before that data, the group of people they want to contact have questionnaires sent to them. So normally that's sent in the post, but there is an online option if people would prefer to answer the questionnaire that way. It's sent to people who are over the age of 16 with a confirmed cancer diagnosis. And then the people need to have been discharged from their cancer treatment during April, May, or June of that year. And they could have been treated either as an inpatient or as a day case patient. And then usually we see the results published around July, but actually, at least let's put that there. Generally speaking, I'd say it's September, and then the trusts have an opportunity to look at those results and then develop action plans of how they're going to address any of the feedback. The reports are all available publicly. If you wanted to go on to that website, you could see the results for previous years. Now in 2020, so that was the last time the survey was done, and when we had results. Currently, the 2021 is being analysed, and we'd expect to see those results, as I said, in September. But in 2020, it was COVID times. And so it was a voluntary thing where the trust actually wanted to be involved in doing the National Cancer Patient Experience Survey. Across the country, 55 trusts, took the option up. So the reports actually were quite limited, and so national comparison wasn't really made during that time. And we had 2 trusts in the Alliance that actually participated, the Great Western in Swindon and Royal Berkshire in Reading. And those results were published in 2021. And actually the program that Nisha spoke about was an outcome of the Reading results and some improvement work that was done. And so then in 2021, there's a new questionnaire that's been developed. And so there's some changes with the way they're actually going to present that data to everyone. So in the past, where there had been a certain threshold, they wouldn't publish that data for where there was a smaller number of patients, but actually they've decided to lower that number this year to make sure that we're getting more information coming through. There's now 36 cancer types rather than 13 tumour groups. So for example, in gynecology, rather than a gynae questionnaire going out, it'll be more specific. There will be endometrial, ovarian, cervical, etc. Coming through. There's also going to be specifics on mental health and learning disabilities, which is something new for this year, which is excellent. And then they are also going to do a 2-variable analysis of the data. So that's sort of looking at demographics alongside the data and how they interpret that. There'll be an easy read version of the information. And there'll also be a thematic report that's from the free text that will be collated. And so this just gives you a little example of the different ICD-10 codes that are used in, which is a type of coding that's used for cancer in the National Cancer Register, and which codes they'll be looking at for the different tumour groups to make up that 36 patients. And then on the right just shows Lisa's working of how the reports have been created in the past. The last slide, I think we'll skip over that, but what we would like to do is to make sure you're all involved in the results. So one of the things that we'd like to do is, as the results come through for this year, we'll work with the trust to see individual sort of reports and actions that they'll be taking forward. There's usually something called the National Cancer Collaborative, which is a specific project that trusts can be involved in actually looking at a certain item and doing what we call a quality improvement project to see about improving a specific aspect and having a working party to develop that. And that's what Nisha's group had done in Berkshire, which was excellent, and the results that were shown there. Lisa will then also be collating the results as an alliance, so we can see overall what the key themes have been. And one of the other areas that we'd like to be involved in is actually the acute oncology service. The clinical lead for that clinical advisory group is keen to look at the patient narrative, the sort of comments that come through the National Cancer Patient Experience Survey, and to take those comments and do thematic sort of analysis by trust and then as an alliance that we can use to help with evidence of perhaps how we can improve that patient experience going through an emergency setting when unwell as a consequence of their cancer treatment. So that's one of the specific projects that we're thinking of and as an alliance to take forward to help. But obviously would be willing to hear other ideas.
Okay, has anyone got any sort of comments or questions for Lyndall? No? Okay. If not, then we'll just finally go on to, thanks for that, Lyndall. That sort of explanation of quite a complex picture, but I'm sure we'd all look forward to the results coming out in September. Okay, so that takes us on to any other business. Does anyone have anything else that they want to raise? Right, yes, Peter, go ahead.
Thank you. I'm an engineer. I specialise in my later career as a mentoring people, engineers for whom English is a second language. I noticed that there's a very interesting discussion at the last meeting about the workforce steering board, primary care education. My question is, what are we doing about the education and formation of the engineers and technicians who will take on all the take on 24/7 responsibility for all of the wonderful machines, the CT scanners, bariatrics, surgical robots, wonderful machines, who is going to be maintaining them and making sure that they deliver 24/7 service? How are we going to ensure that those people have a very satisfying career within the NHS, please?
Right, I think that's a very important question, and obviously we can't address it here at short notice, but I think Peter will certainly take a note of it and look at how we can deal with it perhaps at the next meeting. Okay,
Thank you.
Thank you very much. Alex?
Thank you. I run the Learning Disability Partnership Board in West Berkshire and oversee the learning disability projects throughout the whole of Berkshire. And one of the problems that we've been having is national screening, and the fact that the letters, when they come through, they're not easy read, and there's no way that there seems to be for the flagging systems nationally to identify patients who have a learning disability. So my suggestion is, why don't we all receive easy read? Because that would help anybody, you know, any one of us can have easy read. So if every patient is invited using an easy read invitation, easy read literature, and there can be links so that you can look up further information yourself. I just wondered what the group thought of that.
Okay, could you just explain for those who may not know what easy read is, please, Alex?
Oh, so yes, sure. So it's usually pictorial as well, against some very layman's everyday words. Right. So, you know, we wouldn't talk about equality and equity and quantitative data, you know, we would just use everyday words. So a simple invitation would simply say that you're being invited to go and see your doctor for some tests. It wouldn't necessarily say it was cervical cancer or anything else, but there are some great easy read information about specifically that. And I just want to know, especially with people where English isn't the first language, easy read and with pictures as well is going to help. So it was just wondering whether that might be a way around it.
Yeah, thanks. That's a very good point. I see lots of nodding, Alex. So I don't think you've got any disagreement from the group. Anyone got any other final points of any other business? No. Okay. I think that brings us to the end of the agenda. I think, unfortunately, Lindell's sort of dropped off, so I can't bring up the pack again. But the final slide was just reminding us of the next meeting date, which I think is on the agenda. So again, we'll be sending out prior to that requests for any items that people want us to consider. Because as I said at the last meeting, I'm very keen that this. Oh, here's Lindell back again. Hi, Lindell. I'm very keen that you know this is an interactive meeting, which I hope this one has been, and I think it's not just a question of sort of an agenda being created that people don't have an input in. I think it's very important that you have that. So we've put in place this kind of mechanism to enable you to do that. Lindell, can you just finally put up the last slide?
I'm so sorry, my computer just crashed.
Yes,
and I apologise that I think I got the main message across about the National Cancer Patient Experience Survey. Did anyone have any questions or comments for me that I can take away?
No.
No? Okay. Unfortunately, because my computer's crashed, Kath, I'll come to you first. Thank you.
Can I just check with you, the patient survey, does it now cover all types of cancer, or is it still only, I can't remember, is it specific ones, or just does it cover everything? I can't remember.
It doesn't cover absolutely everything, but there's now 36 subtypes within the 13 different tumour groups. Okay. So on the whole, it's where there's very small numbers, they tend not to look at, that's a more specific piece of work that they would do looking at patient experience. So it tends to focus more on the larger tumour sites.
Okay, thank you.
Okay, thanks.
And Pete?
Peter?
Yeah. Yes, thank you, William, for information only. I'm very impressed with all the work that Lyndall is doing. I'm very willing to get on the train from Reading to Swindon because I will certainly try and start an email conversation with Lyndall outside this between now and the next meeting.
Okay, thanks for that, Peter. Okay, thanks everyone. I think we've reached the end of the meeting, just slightly over time. So thank you all very much for your participation. Do let us know about any items you want us to discuss, for the next meeting, and enjoy the rest of your day. Thanks very much, everyone. Take care. Bye.
Thank you all. Thank you.
Bye.